Hey guys, Michael here again. This is a quick video about arterial line waveform interpretation and the safe transport of a patient that has a arterial line in situ. Now, in critically ill patients, indwelling arterial cannula are routinely inserted for continuous blood pressure monitoring and to obtain blood samples for blood gas, glucose, and electrolyte analysis. The bedside measurement of arterial pressure values from waveform analysis can assist and facilitate the rapid diagnosis of cardiovascular insufficiency and also monitor the response to the treatments aimed at correcting either hypo or hypertension or any other electrolyte imbalances that might be found through the sampling of the blood. Now, following successful arterial catheterization, the connection of the catheter to a pressure transducer should reveal an arterial pressure waveform that can be used to assess a variety of vital sign trends as well as ongoing patency of the line. Now, the indications for arterial line monitoring include all critically ill patients with hemodynamic instability, vasoactive infusions, a requirement for highly accurate and continuous blood pressure monitoring. So, this is quite useful in your septic patients, and requirement for frequent arterial blood gas measurement so that you can keep an eye on the trends of acidosis and alkalosis and the electrolyte imbalances that may be occurring. Now, the equipment that is required for the setup and continuous monitoring of an arterial line includes an arterial catheter set, skin prep, gauze skewers, and sterile occlusive dressing, suture kits to secure the outline in place, local anesthetic, sterile drapes, and then also the giving set, a pressure bag, the transducer for the outline, as well as a bag of normal saline and an ultrasound machine if necessary if you're finding it difficult to find the artery. So the procedure to assess arterial line waveform and ongoing safety and accuracy of arterial line measurements. First of all, you want to receive a bedside handover from the clinician in charge of patient care. You want to identify the goals of care for this current patient. So what mean arterial pressure are we currently aiming for? Are there any parameters in terms of systolic and diastolic limits, upper limits, lower limits? What current medications are being used? To maintain that blood pressure or affect that blood pressure. Once we've done that, we want to ensure the line is sutured in place. So we want to visually assess the outline location. So we're ensuring the line is sutured in place, it's well dressed, it's kept clearly on view at all times. We want to assess for signs of infection, inflammation or leakage, or any distal capillary, any distal perfusion problems that we might be having. So we want to ensure that the following conditions are met to ensure ongoing accuracy of the arterial line. So the cannula should be properly placed within the lumen of an unobstructed artery and the cannula isn't kinked or blocked. The arterial waveform should be evident on the monitor. Now if it's not, you should attempt a square wave flush test of the system. This test should return optimally damped oscillations, so 1.5 to 2 oscillations before it returns to the baseline tracing. It shows that you're getting accurate results from your arterial waveform. If it's underdamped, we'll have greater than 2 oscillations, so we're overestimating systolic pressure and we're underestimating diastolic pressure. If we're overdamped, we'll have less than 1.5 oscillations, and then we're underestimating systolic pressures, and diastolic is probably not going to be affected by this. Now, if we have tried a square flush test and we have any issues with the oscillations, we might have to change the tubing or even the whole site that we have the arterial line in place. After this, we want to make sure that the cannula is connected by a short, rigid, wide bore tubing to the transducer. So this stops kinking of the tube with movement of the patient and allows for more accurate measurements. If a rigid wide bore tubing is not used, we need to immediately replace this with some appropriate equipment to ensure ongoing accuracy of the waveform. So we want to make sure there are no air bubbles in the tubing or the transducer. The arterial waveform should be evident on the monitor. If it's not, we need to attempt a square wave flush test, of course. An over-damped system suggests air bubbles could be in the system and it's falsely lowering our pressure measurements. We need to flush the system of the air bubbles, and if this doesn't work, replace the tubing, and once again, if this doesn't work, we're going to have to change the site that we have the arterial line in place. We also want to make sure that the transducer is leveled and zeroed to the desired point on a supine patient, which is the level of the right atrium, also known as the phlebistostatic axis. So to determine the phlebistostatic axis, we need to draw an imaginary vertical line from the fourth intercostal space to the lateral aspect of the chest, as indicated by the line A. We then need to draw a secondary imaginary line horizontally at the level midpoint between the anterior and posterior surface of the chest, as is indicated by the line B. Now the intersection of A and B is the phlebistostatic axis, which should be at the level of the right atrium. Now once we've done this, to zero the line, we need to ensure that the transducer, pressure tubing and flush solution are correctly assembled and free of air bubbles. We're going to place the transducer at the level of the right atrium, the phlebistostatic axis. We're then going to switch the line off to patient and open to air. Now, zeroing the line at this point sets the zero reference point as atmospheric pressure. So any difference from atmospheric pressure is then what gives us the reading of our blood pressure. So whenever the patient's position is changed, if they're sat up, if they're raised, lowered on the bed for any particular reason, we need to make sure that the transducer height is altered in the same manner. So if we sit the patient up, the patient's heart is going to be higher than before. We need to make sure that we raise the transducer at the same time. We should also zero the line whenever there is a movement, just to make sure that we're not going to be changing any of the outputs of the waveform. So the arterial waveform itself can be broken up into 5 different sections. As you can see on the picture here, we've broken it up A through E. Now point A is the upstroke of systole as blood is ejected from the left ventricle, and this causes an increase in blood pressure. Now point B is peak systole, so this is when systolic ejection has occurred and the opening of the aortic valve is allowing blood to come out through into the circulation. Point C is a decrease in pressure during systole, but at the start of cardiac muscle relaxation. The small upturn, the dicrotic notch, is point D. Now this is the closing of the aortic valve and interrupts the arterial downslope. It occurs just moments after the start of diastole. And then point E is at the end of diastole, the waveform returns to its lowest point. So interpreting this in blood pressure, you can see that point B is going to be our systolic blood pressure. Point E is going to be our diastolic blood pressure, and the area underneath the waveform is our mean arterial pressure. Now the decision to insert an arterial catheter needs to be made with an understanding that it always carries defined risks such as bleeding, thrombosis, infection, distal perfusion compromise and emboli. If bleeding does occur, it's important to remember that direct pressure must be applied for a minimum of 5 minutes, as this is an arterial bleed. And in the presence of profound vasoconstriction, it's important to remember that femoral arterial blood pressure measurements are more accurate than radial artery measurements. Another important thing to remember is that if a patient has an infection over the proposed catheterization site of the artery, this is a contraindication for the implementation of an arterial line. Some machines allow for continual trending of vital signs and measurements that are taken by an arterial line. However, it is important to take note of measurements at regular intervals to assist in the early identification of ongoing patient condition, trends and pathways. And you also want to make sure that you're regularly noting the time that the line was last zeroed to ensure ongoing accuracy of the arterial line waveform, and if it is a time for that line to be zeroed once again. Alright guys, thanks very much for listening.